Okay, we're going to continue on with the rest of the morning. Please have a seat. Okay, it's really my pleasure to welcome our next two presenters, Callan Thornton and Dr. Lori Halmo. Callan Thornton is focused on bridging gaps in maternal behavioral health care through strategy, innovation, and community partnership. She is the manager of the Gender Responsive Services within Colorado's Behavioral Health Administration and the senior staff authority on gender responsive behavioral health treatment and on substance abuse treatment for pregnant and parenting women. She is a clinical social worker by background, and Callan is committed to ensuring that the systems, policies, programs utilized by pregnant and parenting families are responsive to their unique needs. Dr. Halmo is a medical toxicologist and an assistant professor of pediatrics in the section of hospital medicine, the University of Colorado School of Medicine and Children's Hospital of Colorado. In addition to her clinical work as a pediatric hospitalist and medical toxicologist, Dr. Halmo is involved in numerous quality improvement initiatives related to the care of hospitalized toxicology patients, with a particular focus on children and maternal infant dyads affected by substance use. Thank you both. Hi, Callan.
Right. Good morning, everybody. Thank you so much for this opportunity. Oh, okay. Thanks. Good morning. Thank you so much for this opportunity to get to talk about these new toxicology guidelines that have recently been completed, and we are just starting the implementation process for. So my name is Callan Thornton. I use she, her pronouns. And as Susan mentioned, I work for the Colorado Behavioral Health Administration on a number of different maternal and child behavioral health initiatives. And today I come to you in my role as one of the co-chairs of Support Colorado's Policy Analysis Work Group. So Jay did a great job talking about the mission of support of Illuminate Colorado and the Support Colorado Steering Committee earlier. So I won't spend too much time talking about that. But I mainly want to let you know that Support Colorado is tasked with implementing strategies for reducing the number of families impacted by substance use during pregnancy and for improving outcomes for families across the lifespan. Illuminate has also been really involved in some important legislative efforts over the years that you can see up there on the screen. And the one that I want to highlight today that to me is very directly related to the need for Colorado to implement some consistent, clear, transparent, trauma-responsive toxicology testing guidelines at our birthing facilities across the state is directly related to Senate Bill 2028. So what this legislation did was ultimately shift the definition, change the definition of child abuse and neglect. In the past, substance exposure during pregnancy was an automatic finding of child abuse and neglect, and a case was automatically opened. What this change in language does is it moves the language to say that an infant must be born affected and threatened by, and the and threatened by piece of that language is really important. So affected and threatened by their birthing parents' substance use. And what this does is it creates a lot more space for those of us, myself included, who are mandatory reporters, who work in birthing settings, to be able to get more context and to really come around a family and provide referrals that are appropriate for that family's strengths and their needs. And so an automatic reflexive report to child welfare isn't always appropriate or targeted to that family's specific strengths and needs. And so what this legislation does is it creates a lot more room for things like toxicology testing policies to have us all pause and think a little bit more and to de-emphasize the focus on a positive toxicology test and to really look more at contextual and behavioral factors that are much more appropriate indicators for a parent's ability to safely caretake for a child. So this is just a picture of the changed language that we talked about. So it used to just really focus on that positive test and talk about the schedule of the substance. And now it's really talking about that must be born affected and threatened by. So for just a second, I want to talk about the why of toxicology testing, why the policy analysis work group has spent the last year and a half working on these changed indications for toxicology testing. You all might remember from last year, Dr. Davida Schiff gave a very compelling talk on this topic. And so we really felt that there was the need for a Colorado-specific policy. One of the reasons for this is that current state is that there's huge variation in toxicology testing practices and policies across the state. Some hospitals and birthing facilities have policies, some don't have policies, or there's unspoken policies that kind of run clinician to clinician for how toxicology testing is administered or indicated at that facility. This variation in practice and the lack of a clear, transparent policy lends itself towards structural racism and classism, as we know that families of color and of low socioeconomic backgrounds are disproportionately tested and disproportionately referred to child welfare. And then we also know that families of color are disproportionately represented in our child welfare system, despite the information that Mandy shared earlier, that families of color are no more likely to be using substances than their white counterparts. So we have to confront the fact that the way toxicology testing has been done historically has racist and classist roots that continue to be perpetuated in the medical system. We also have the data that Susan shared from those recent reports that criminalization and these punitive policies actually have the opposite effect that I know all of us are going for. So they result in people not seeking prenatal care or receiving inadequate prenatal care, which we know is one of the most important factors to having healthy maternal child outcomes. So that's one of the big whys, is that we have to, in my opinion, we really need to acknowledge that the way toxicology testing has been done in the past and is still being done across many parts of the state has the potential and actually does cause harm. And updating our toxicology policies based on evidence and data and what we now know in terms of improving maternal child health outcomes, in my mind, is low-hanging fruit. There's so many complicated, nuanced, big issues that we're all facing when I'm trying to wrap the best care around pregnant and parenting families. But this is, in my mind, kind of a no-nonsense, logical thing that we can put into place to try to stop or slow down some of the harm that gets done by toxicology testing, and to do it when it has to be done, to do it in a way that's responsive to families' needs and that's trauma-informed and that actually achieves the outcomes that we're all looking for, which is improved maternal and child health outcomes. So I want to just give a quick shout out to the policy analysis work group. A number of you are here today and have contributed so much to the development of this guidance. Thank you so much. I want to note that this guidance has been reviewed by subject matter experts across the state and nationally as well. So this includes pediatricians, neonatologists, obstetricians, clinical social workers, child welfare professionals, maternal and child health policy analysts, lactation consultants, emergency department physicians, addiction medicine physicians, birthing people with lived experience around pregnancy and substance use, quality improvement professionals, and lawyers with expertise in maternal child health. So the policy guidance, the guidelines you're about to see today have had many, many eyes on them, and it has been quite a labor of love over the last year and a half. So thank you to all of you who have been involved in that and who are hopefully going to be willing to help us with implementation of these guidelines across Colorado. What I hope you do after hearing all of this is that you go to your respective places of practice and advocate for the development of a clear, transparent toxicology testing policy at your place of practice. I believe that this guide is a necessary step to prevent ongoing perpetuation of some of the harms that we talked about earlier, and is an opportunity for us all to do better by pregnant and birthing people and their infants. So I'm going to turn it over to Dr. Lori Halmo, who was critical in informing the development of this policy, and she's going to get into more of the nuts and bolts. Thank you so much.
This microphone is very tall. Hi, everybody. I'm Laurie. Gosh, it is really hard to follow Diane and Callan, but I'll do my best. As Susan already mentioned, I'm a hospitalist and a medical toxicologist, and I do a lot in this space. In my personal life, I'm also a foster parent. I've got 3 little ones at home. I was already telling Callan I'm like panicking because summer is coming and I don't have childcare, but that's a separate story. P.S. If anybody wants to be a babysitter, please contact me. I'm gonna move forward here. All right, yeah, that's me. No disclosures. So in terms of what we're going to cover today, I could talk to you all day, literally, about this policy and show you a lot of data. And we just don't have time for that because there's other things that we want to talk about today. Everyone can read the full set of guidelines. So I'm not just going to show you like a million screenshots because you can do that later. I would like to try to show you some data and kind of walk you through why tox testing has its own inherent problems, just methodologically, walk you through the potential for harm, which I think has already been discussed actually pretty well today. So I'm not going to totally go crazy there, and acknowledge that there is a place for tox testing too. Talk a little bit about informed consent. That's another piece that, again, we could talk about that all day long, but we'll just touch on that briefly. And then spend a little time talking about what evidence actually shows us as far as kind of where tox testing has some utility and where it maybe falls short of what we would expect. So just to start out, tox testing is not what everyone wants it to be. And I say this as a medical toxicologist, like I tell people to order tox tests all the time. And I also tell them when to not order a tox test a lot. Elena Dillner wants to request remote control of my screen. I don't know if that's okay or not. I don't know who that is. Sorry, Elena. You're probably a really cool person.
We can't see any of the slides on the virtual. I don't know if you can hear me.
Oh, so you want to hear approve?
Well, let's give it a try. We called Amy to see.
Let's see approve. Let's see if can you still advance?
I don't know.
Okay.
It looks like yours are still.
Okay.
And they're up
All
there.
Is that okay?
Okay, cool, great. Yeah, totally. No worries. I just wasn't sure. It's all good. No, thanks everyone. Sorry. Little comedic relief there. Okay, cool. So tox testing. Okay, so pretty much a tox test might, note the capitals, maybe will tell you if a person was exposed to a particular substance or one of a class of substances. That's pretty much it. That's all it can tell you. Maybe. It's not going to tell you who gave that person the drug, how they took the drug, how much of the drug they took, when they took the drug, whether or to what degree that person was impaired or intoxicated. And most importantly, it is not a parenting test. And we conflate that all the time, right? And historically, the law also conflated that, right? That's a huge problem. And certainly I was sort of raised, as sort of a young physician in this era where this was taught to me as gospel, and it's not. So I think probably everyone in this room, by virtue of the fact that you're sitting in the room or here virtually, kind of will accept that at face value because you guys are really cool. But not everybody is going to, sorry. The mouse is moving all by itself. I don't know. Sketchy stuff going on. Just gonna ignore that. So let's do a little exercise. Raise your hand if you have ever in your life cared for a child, either because you're a parent or you babysat or somebody like voluntold you to do that for your like little nephew or whatever. If you've ever done that before, cool. Okay. Now, those of you that raised your hands, put them back up again and keep it up if at any point in your life prior to caring for that child, you were exposed to any of these medications, like an allergy medicine or a cough and cold medicine, or you took something to help you sleep, or you had a glass of wine, or whatever. Pretty sure every single hand stayed up. Cool, you can put your hands down now. Now raise your hand if you think that because you took one of those things sometime in your past, you were not fit to care for that child. We got one hand, but I think you're doing pretty well now, James. That's what it seems like. So I think the point stands, right? Like, we all do this all the time. And it's not only socially acceptable, it's like necessary for a lot of our health and well-being to take prescribed medication as it's prescribed to you, etc. Right? And the lay public, the law, and also healthcare providers all the time conflate illegal substance with equals mind altering equals not fit to parent. But we have lots of legal and prescribed substances that are air quotes mind altering. And we want people to take their prescribed medications, right? We want people to have access to, all the things that we use to elevate our health and well-being. So I'm not going to belabor this point, but I just use this exercise to demonstrate that we draw an arbitrary line in the sand and it's arbitrary, right? Okay. So jumping in as sort of a preamble to getting to the nuts and bolts of these guidelines, there are some confusing words out there. We're just going to talk about a couple of them. Screening versus testing. This is always this eye roll in my head because we use this term a urine drug screen. And what I mean by that is within the realm of testing, there are different types of tests. And one of those tests is considered a screening test. But really the appropriate name for that would be a urine drug screening test. Because screening, as most people kind of use that term, just means getting information, typically from the patient, about whatever you're screening for, in this case, substance use. So that means talking to the patient or asking them to fill out a questionnaire, taking a history, right? Usually when we talk about screening, like capital S screening, we're talking about using some sort of validated tool, whether it's clinician administered or self-administered, on paper, on an iPad, verbal, whatever. Everyone should be screened using one of these validated screening tools. And there's lots and lots of work going on to try to help people actually make that a reality. We know it's not a reality in many places right now, but it should be. That is different from testing. Testing is when you collect some sort of biological matrix, so urine, blood, saliva, hair, vitreous fluid from the eyeball. You can test whatever you want, by the way. We don't do that regularly, but you can. And then we take it to a lab and we put it through a machine and we assay whether or not there is some substance of interest or a metabolite of that substance present. Just because someone screens positive does not mean they need a test. Sometimes it does. Sometimes a person might screen negative and we still think they need a test. So these two things are not the same. First point. Okay, so I alluded to this. In the world of testing, there are two main buckets of types of tests. There are screening tests, hence the confusion, and there are confirmatory tests. And I'm going to dive into this a little bit more because I first and foremost want you to come away with the understanding that a tox test is not all that it's cracked up to be. So screening tests are usually immunoassays. That's just the type of test that's done in the lab, the kind of mechanism that is behind the test. They're usually qualitative and they suck. They're full of false positives and false negatives, but they don't tell you that when you get the results back, right? They just say positive or negative. And it doesn't say and by the way, there are a million reasons why this actually might be false. It just says positive or negative, and it makes it seem like that is just an absolute fact, but it's not. And we don't get taught that regularly in our kind of clinical teaching. So I'm trying to hammer that point home. So why do we even bother? Because they're fast, they're cheap, and they're everywhere. In contrast, confirmatory tests use a different kind of chemical, metric or method. So these assays are usually HPLC, GCMS, tandem LCMS, whatever. Doesn't matter what is happening in the lab. The point is it's a totally different method than what's happening for screening tests. They're much more accurate and much more precise, but they're expensive and they're slow. And they usually are not done in your hospital's own lab. They have to be sent out. And so for that reason, we don't do confirmatory testing for, the vast majority of the tests that we do send. Otherwise, it would cost $1 billion and it would take 1,000,000 years and nothing would ever actually happen in a timely fashion. So if you're talking about screening tests, which is the majority of tests that are sent, you have to understand that these are not all they're cracked up to be. Let's dive into that a little bit more. These are my 3 tenets that when I talk about urine drug screening tests, these are my 3 tenets that I try to get people to understand. Some of them are kind of obvious, but they're easy to overlook in the haste of clinical care. So first of all, what you find depends on what you look for. Duh. But I hear people talk about this all the time. They talk about the tox test, like there's only one. There's a gazillion of these on the market, right? So if you go take one at doctor's office A and then you go to doctor's office B, you might get 2 different tests made by 2 different companies with 2 different reagents, with 2 different lists of things that they look for. And you will therefore, I guarantee you, get 2 different results because you're looking for different things. But we don't teach that to people, right? So it's kind of obvious when you think about it, but it's a big problem in reality. Cross-reactivity is a major problem for immunoassays. We talked about that a little bit. This is the whole false positive, false negative thing. The sort of technical term for that is cross-reactivity. And then this one is important too, and again, a thing we don't teach people. There is sort of a threshold or a minimum amount necessary to make a test say positive. That is by design because we don't want every result to be a false positive. And so the manufacturers of these tests try to raise that threshold to a certain amount so that you're not getting just noise that gets interpreted as signal. But it also means that if you're expecting something to be positive and then it's negative, this might be a reason why. The amount that was there was just lower than the test could read as positive, even though it really was there. So I'm going to dive into a couple of these a little bit more. This is just an example. And this slide, I will say up front, for those of you that work at these 3 hospitals, is old. I made this when I was in fellowship, but the point still stands. This is what's on if you just type in urine drug screen into Epic, the EMR at any of these hospitals, you will get a test that looks for these things. These lists are not the same. And so if you take the same person's cup of urine and you pour it into 3 different cups and you run it at one hospital or hospital 2 or hospital 3, you will get different results because they look for different things. And the amount of variability that's out there is very, very wide. So if you're a clinician who is new to a particular institution and you're used to your old institution, which maybe looked like Children's, and in fact, your new institution looks like Denver Health in terms of what people look for, you are going to potentially grossly misinterpret your results because you're expecting that list to be much longer or the potential list to be much longer or vice versa. Cross-reactivity. So again, we could go talk about this all day, but I just want to show you something to kind of make this point. Why does cross-reactivity or false positive or false negative happen? It's mostly due to structure. This is a chemical problem. So I'm showing you the structures of morphine, hydromorphone, and fentanyl. And you can see that morphine and hydromorphone look really similar, and they look really different from fentanyl. And this is why if you order an opiate screen, morphine is going to make it positive. Hydromorphone might make it positive, and fentanyl, I guarantee you, will not make it positive. It's because the immunoassay is looking for morphine. That's what they're usually based on. The manufacturers make the test to make it look for morphine. But if you have something like fentanyl on board, it doesn't look anything like morphine, so the test reads negative. But we see this happen all the time where people interpret a negative opiate screen as not containing anything that would affect the mu opioid receptor, and that is not an accurate interpretation. Let me really blow your minds. So Everyone's just like, this is so frustrating. So here I have side note, big thank you to Geza Bodor. He is the old lab director at the UCH lab. He gave me this data to make this slide. So Cedia and Siva, I'm not even saying that right, are brands. These are companies that make these different drug assay kits that labs use. And Cedia in particular makes a bunch of different ones. There's the AE, the AS, there's like all these different series, you know? And it turns out that if you want to do an amphetamine screen on someone and you run it on Cedia's AE platform, and then you run it on Cedia's AS platform, and that person, for example, took some, that person took some L-amphetamine. By the way, amphetamine can come in two flavors, D and L. Those are the racemic isomers, so they're like mirror images of each other, the chemical structures. D-amphetamine is usually the one that we think of as being illicit, and L-amphetamine is licit, so it's legal amphetamine. That's not why they're called D and L, it's just a way to remember it. So let's say you took some legal amphetamine, whether that was, you took your prescribed ADHD medication that day. Well, on the Cedia AE screen, that's not going to show up as positive because it's designed to not find that drug because it's known to be a legal substance. But on the Cedia AS platform, it does show up as positive. That's the same company, just two different models of their testing platform. And it goes on and on. You can see the numbers here don't matter. The point is where the numbers are different, the degree to which that test can look for that substance is different, but the same substance, right, across these different panels. So your lab might decide that tomorrow they're going to use a different platform than they were using today because the reagent's not available for the original platform, or it got a lot cheaper to choose platform B. And they don't have to tell you that, by the way, but it affects your interpretation of the results. So this really makes it hard to interpret these results appropriately, right, in the context of the patient. I could go on about false positives. This is not a comprehensive table by any means. This is a very, very brief kind of smattering just to make the point that lots of things that people take because they're prescribed to them or because they're over the counter, like a decongestant or whatever, can make some of these scary things on a tox test look positive. And if you don't bother to ask or dig deeper, you will probably misinterpret these results. Okay. So I think I've made this point a lot of ways now. Tox testing can be harmful. First and foremost is the inappropriate interpretation. We've really, I think, hammered that point home. We've talked already about the racial and ethnic disparities in child welfare reporting, specifically as it relates to substance use. There's sort of a landmark paper by Sarah Roberts and some of her colleagues that's actually cited in the guidelines that we're talking about today that demonstrated that Black children are 4 times more likely than white children to be reported specifically with substance use concerns. And yet in that same cohort, the rate of drug use or substance use, I should say, it's not just drugs, they were looking at other things, substance use, including alcohol, in this cohort was the same between white and Black moms. And so not surprisingly, this can lead to a huge amount of damage to the therapeutic alliance between you as a clinician or provider and your patient, especially if you don't handle this well. And I think Diane really did a great job of explaining how poorly that can go and how much harm that can cause. On the flip side, sometimes we really need this information and it can be helpful. So in my case, we'll talk about some of these indications later, but I get called in a lot to see people who are literally dying. And I don't know why they're dying. And sometimes this can help me get a better understanding of why they might be dying. Sometimes if somebody is engaged in therapy, this can be a good way to demonstrate their sobriety or compliance. So sometimes we are actually looking for the test to be positive because we want to make sure you're taking your prescribed medication, right? And so tox testing can be useful to demonstrate that. And sometimes we'll talk about this in a moment. This can be useful to help inform the safety of breast milk use. That's a big part of the policy as well, or I should say the guideline, as well. A quick word on informed consent. Again, could talk about this all day. I would argue that informed consent is actually an opportunity. And I get it. I am also a clinician. I also see a bazillion people every day, and my phone never stops ringing, and I'm hearing the code alarm going off. And like, I so understand how dedicating 30 or 40 minutes to having this conversation feels like an impossible task. And yet, I think it's A, incredibly important, and B, sometimes, like we talked about, sometimes you really need a tox test. And if you really need a tox test, you don't want to get it at the expense of this relationship. So like, I would argue this should be way up there on your priority list to make the time. I would tell you an anecdote right now about a time that I was on a few days ago, but we don't have the time right now because I realize we're already behind schedule. But suffice it to say, I learned a hard lesson when I was on as a hospitalist the other night, trying to get consent for an LP that was, in my opinion, routine. And I learned the hard way that nothing is routine, and people are not going to let you walk away if they have ongoing questions that you haven't addressed. And so the point is just make the time. If you make the time, this can actually be a really beautiful conversation. And I've had this go really well too. But in order for that to go well, you have to make the time. I think that really, if you're testing a birthing person, you should not be obtaining a test unless the patient consents or they lack capacity. And that's a very specific circumstance for them to lack capacity. There's more about that in the policy. For newborns, really it's best practice to get consent too. I recognize there are times as clinicians where we need that test. It's genuinely medically indicated, and we suspect or confirm that we cannot get consent from the parent. If you don't have consent, you better have a 4 asterisks good reason for ordering the test, right? And sometimes that exists. That there are times where that is true, but you better be able to say with really clear and precise language how the result of this test is going to change your medical management. And if you can't really articulate that, you should not be ordering this test. We're going to get into that again. So a little data. So this is just a list that I threw together. It's not by any means comprehensive, but here are some reasons why in the past people order tox tests. Again, not comprehensive. And I should say in the perinatal period specifically. And I hope I can show you in just a moment that turns out the data for this is pretty crappy. So here's an older study now, but I think still relevant. This is looking at the diagnostic yield of newborn drug testing. And you can see that this group, it's pretty straightforward. They had a bunch of babies, they had a bunch of tox tests sent, and they went back and they did a ton of chart review to determine if the results of their drug testing were either nothing, there was nothing there, or there was something there, but everything was explained by prescribed medications that we knew that the birthing parent was taken, or we discovered that there was clear evidence of non-medical drug use, or there was something that was found that was sort of unexplained. That was the smallest group. And I will just draw your attention to the lack of asterisks in this table. Usually the asterisk is what tells you that a result was significant. So here, none of these things were significant. Things that we use all the time and that I was taught in medical school predicted drug use in a patient. Placental abruption, congenital malformations, unexplained prematurity. In this particular study, interestingly, history of child abuse or protective services involvement also did not identify people with a positive tox test any better than it did people with a negative tox test. What was positive? Basically, a history of drug use, which you can gather by talking to the mom. So you don't actually need a tox test to identify this. If mom tells you openly, I use substances during pregnancy, probably the test will be positive and you don't really need to run it, right? Interestingly, tobacco use in many, many studies is consistently a very reliable indicator. And we don't use that, I think appropriately, because we realize that there are lots of reasons that people smoke cigarettes, and it's not always that they smoke cigarettes because they're also using other substances. But if you want to use data as a gotcha to say, I'm going to find these people that are hiding their drug use during pregnancy, that's probably your best bet. But we all sort of know, that doesn't really make any sense, right? And yet we try to use these indicators that actually don't have evidence for them. So that doesn't make any sense either. Okay, that's the newborn. What about mom? Similar study using moms. These were urine screening tests, sorry. And by the way, these authors, this was done in our local area here in Denver. This is from 2018, so it's a little old, not super old. And again, this one I should point out, they didn't use asterisks in this table, but you're looking for a p typically less than 0.05, so on that like far right hand column. And what you can see here is that it looks like there was maybe some significance in the any obstetrical complication driven by threatened preterm labor at the very bottom. But actually, if you pay attention, you are more likely to identify a negative test, not a positive test. So that's not really what we're looking for as a general rule. What was positive? Again, if the mom told you she used drugs during pregnancy, it's probably going to be positive. That was really the most important thing. There were a couple other things in this particular study. No prenatal care, not scant prenatal care, but no prenatal care was predictive, and current tobacco use, like we talked about. And in this particular cohort, a history of having child welfare involvement was also predictive. But I think, again, that's the kind of thing you can talk to someone about. You don't need a tox test to determine whether or not somebody had child welfare involvement. In fact, it's probably a pretty poor proxy for that, since lots of people have child welfare involvement who don't use substances. So it's not really a sensical test for that, right? And it's certainly a lot cheaper and faster to just talk to the mom and ask. So given that, this is straight up from the guidelines. I just copied and pasted it into my formatting here so it was prettier and easier to read. When should you test a birthing parent? I would argue if that birthing parent is clinically intoxicated, withdrawing, or altered, and you don't know why, that is the kind of reasons why you like typically call the poison center and talk to me. And I'm probably going to tell you, if your differential is like encephalitis, seizing, positive tox, or, like stroke, probably it's worth it to like check this box, because your workup is going to be substantially different depending on which of those, and that's sort of a made up differential, but which of those, paths you're thinking you're going down. The birthing person may ask or desire a test for a variety of reasons that we've already talked about. And then specifically when it comes to breast or chest feeding, if the person wants to breastfeed and there's either a history of recent use, or the person has an active substance use disorder and they're not engaged in treatment, those would be reasons to consider taking the time to test that person. With a big asterisk, which is that if a person is involved in treatment, please loop in their treatment provider. That person is going to know way more than you or me is going to know about what's been going on recently, what we expect testing to show, and all that jazz. It's going to help not only with knowing whether and when to test, but also how to interpret those results. For babies, it's pretty straightforward. If the baby looks clinically like they're intoxicated or withdrawing, and you need to know because it's going to change how you change their care, right? Their medical management day to day, that's a good reason. If the parent would meet criteria and the results of a newborn test would affect how you medically manage the baby, that's another legitimate reason to get a test. But that last part, I think we as clinicians have a tendency to stretch that a little bit. And I would argue that for a lot of things that we look for on a tox test, it's not actually changing what I order day to day. So you want to just be really thoughtful about how cannabis use, for example, is going to change what you put in your orders that day. And then we have a separate sort of section on physical stigmata of FASD, so that's fetal alcohol spectrum disorders. There's an asterisk there to remind me to tell you that many tox tests that we run on babies will not include ethyl glucuronide, which is what you are looking for if you are trying to determine if there was alcohol use during pregnancy. Some tests include that as standard for various newborn matrices and some don't. But if you're specifically looking for alcohol use, again, what you find depends on what you look for. If you're looking for that, please make sure that the test you order has what you think you're looking for as a choice. So here are just some examples, and I know we got started a little late, so I'm going to wrap it up here quickly. Just some examples of things that we might historically have chosen to run a tox test in these cases, but in fact, if we run one today and we send off our results to child welfare is probably not going to investigate further. So some examples might be, this person has a remote history of child welfare involvement, but nothing currently, or this person has a remote history of substance use, but nothing currently. Yeah, they're not going to investigate that. Or this person used substances during pregnancy and they, kind of got into treatment and now they're doing better. And there's no ongoing concerns for mom or baby. That's unlikely to be investigated. Here's one that I think is still something that clinicians struggle with sometimes. So in this case, the birthing parent and the infant, everyone agrees, are in fact impacted by the substance use, but the parent or caregiver in question can still meet the physical, medical, and developmental needs of the child because some of these other things might exist, right? There's another caregiver involved who can help. Or the primary caregiver decides to enter into treatment right then and there. Or the caregiver has a ton of support, like what Diana was talking about, right? They have their 1, 2, 3, 4, 5, 6, 7 people that are going to like really kind of encircle them and help them through this difficult time. If that's the case and we can demonstrate that, child welfare is probably not going to get very involved. In contrast, if a caregiver can't meet those needs and it's been really clear, like they're not waking up to feed the baby, they are not comforting the baby is not able to sleep or eat, the caregiver doesn't respond when the infant cries, right? These are reasons that child welfare is probably going to get involved because it's pretty clear that as it currently stands, this caregiver is not able to meet this baby's needs. The caregiver is actively intoxicated or in withdrawal. The caregiver just leaves. That happens, unfortunately, sometimes. Or the caregiver, maybe wants to do all these things, but doesn't really have a plan in place. They don't have that circle of support, and they can't really figure out how to get there. Those are cases where probably at least an investigation is going to be opened to see if there are things we can do, that are less drastic than potentially removing the infant. So we're going to close it out, and I realize that this was a whirlwind tour, but if I can leave you with a couple of just like take-home points, it's complicated. It's sometimes useful, but it also can be really harmful to tox test people, and you want to really make sure that you address that internally and externally via an informed consent procedure before you order a tox test. And if you are going to order one, please be able to articulate very clearly how your results are going to change your medical management, because this is not about gotcha. It's not about finding that needle in a haystack of somebody who is trying to hide their substance use, because that's the end all be all of a parenting test, right? Awesome. Thanks, everyone. What an appropriate time.
All right, we'll open up for questions. You'll have to pick up an L and then we'll bring the question.
Okay, sure.
Hi, I work at a tertiary care facility where we have a hospital for premature and complicated pregnancies, and we run a lot of cord stats. I wondered if you have any opinions or advice about that.
Yeah, so cord stat is usually when people are talking about that, they're talking about testing an umbilical cord tissue as the matrix for testing. So just as I have a lot of thoughts. I'm going to pare it down. Oh, and sorry, I was supposed to repeat the first part of the question in case it wasn't clear for the people on Zoom. So do I have thoughts on cord stats is the question. So umbilical cord testing became a thing not because umbilical cord tissue is the best, air quotes, best matrix for testing. I don't even know how you would define the best matrix, but it's certainly not the matrix that we have the most information or data for. It's not the matrix that is cheapest to test or fastest to test. It is the matrix that is most convenient to obtain. And that is why it has risen to prominence, not because it finds drugs better or faster or cheaper. Problematically, we have so-so data explaining how to interpret those results. There's been a fair amount of work trying to understand, for example, concordance between umbilical cord testing and meconium testing, or umbilical cord testing and like maternal hair samples, which can give you a retrospective view of what happened, 2 months ago, 3 months ago, 4 months ago. And the short answer is that the concordance is pretty good, not 100%. There have been a couple of notable cases of twins, for example, with discrepant results, which is always a little stressful to me. And there has been only one study that I'm aware of that has compared cord and hair, which is really the only way I can think of that you would be able to get data to say how far back, air quotes, does a cord take you. And so in that one study, so limited data, right? In that one study, there were no cases of people that had exposures in only first trimester or only second trimester that showed up in the cord. If you had exposures through all 3 trimesters, or you basically third plus anything prior, it typically would show up in the cord. So I think my high level thoughts are cord is definitely very convenient to collect, and I think it has a lot of promise, but I think we need to know more before we start interpreting these results again as gospel, because frankly, it's pretty new actually, and there hasn't been nearly the testing and the experience with cords as we have had, for example, with urine, which I realize has its own set of problems, but at least we have a lot of experience and a lot of data to help us with interpretation.
I think this will be our last question.
Thank you so much. That was so amazing. I am Sarah Lopez. I'm a community doula. I work with the Recovery Nurse Advocate Program as well as Elephant Circle, and I work primarily with families in this realm. And I really appreciated that you really spoke a lot about how the results are going to affect the case management. But as a doula and somebody who works closely with the family, how do we hold providers accountable if they're not doing that, if they're just doing that gotcha moment?
Yeah, it's a great question, and one that I face a lot. At the end of the day, right, you can't force anybody's hand one way or the other. So even as an MD consultant, I make recommendations, but I don't get the final say in what happens in a person's care unless I'm the primary provider. And so, I sometimes will kind of do a lower key version of my little exercise that we did earlier. Have you ever had a glass of wine while your kids were home? A lot of people say yes, but that's actually totally not kosher if you have an open child welfare case, by the way, which feels a little bit like a double standard to me, but we'll just leave that aside. And so sometimes I try to make it really clear that these are just lines in the sand and we've had to draw them somewhere. And, I think every individual is sort of allowed to determine what they feel in their own heart is, air quotes, right. But that is not the same as what the law says. And the law is pretty clear at this point that just because you had a glass of wine while you were caring for your kid does not mean that you're a terrible parent and you should lose your children.
Caitlin's begging here for a question. Okay.
Literally jumping up.
Yeah, I'm going to jump up and down. I think, Sarah, you hit the nail on the head, is that this interaction, this dynamic is on us, healthcare workers, hospital systems, because by the time a family or doula or peer support person is in the space of declining a test, we've already put them in the one down, right? That's almost an irrecoverable situation. If you have said, no, you can't test my urine, or no, you can't test the umbilical cord. And so we have to do a better job of only asking when it really will change the care of the family. But it can't be we coach our patients to say no, because that's not a neutral event. So thanks. Okay.
Totally agree.
Thank you. Thank you so much, Callan and Lori.